The first, and they've mixed them up now. The first is, should we operate on intracerebral hematoma in light of this Stitch trial? Yes? Or what was it? Stitch? What was it called? Stitch trial. So the Stitch trial said no, but they're having another run at that. And they're having another run at it by saying, maybe if we do it minimally invasive, then the operation will be worth it. All of the early results I've seen so far have said lobar hemorrhage, we probably should operate, for which we don't need minimally invasive because we can do it through a tiny little craniotomy. But the minimally invasive basal ganglia, it's probably not worth doing. So what do you think is going to happen with that? Should we be using endoscopes to take out temporal hematomas?
I think the best evidence are probably going to come out from ENRICH, and they too mentioned that if you're going to use that ENRICH, which is using the BrainPath NiCO, the overall benefits come from the population that is using lobar hemorrhage. And so the actual deep ganglionic hematoma actually didn't really show a lot of significant difference. But we're really waiting for the full data to come out. You're right. But then the benefit seems to come from the Stitch trial and all that had actually showed no functional benefits and not even mortality. I think MISTI showed that there's a benefits in the mortality, but what we want is the MRS log shift. And I think ENRICH is going to come and show that there's going to be that bit of that, the data that is going to show that is useful, but that benefit still comes from lobar. Now, so the question is whether you're going to do a lobar hemorrhage, just do a mini craniotomy and remove? I think so too. So, and the cost and all that, you really have to see. Because, yeah.
That's what worries me, is that we're going to have a result that says, oh, yes, you should be doing this in lobar hemorrhages using our expensive equipment. We won't actually have ever had a trial that looks at mini craniotomy and endoscopic in lobar hemorrhages. We've kind of jumped over that. Anyway, any other questions? How many do you have on your list?
Thank you. Thank you, Professor. I want to ask Professor Vincent about the management of intracerebral hemorrhage. So what is your current methods for intracerebral hemorrhage now? What is your current methods for management of intracerebral hemorrhage?
Just to paraphrase, so what is my current method for ICH? Number one really depends on whether the size of the hematoma and whether the patient has already size of impending herniation. All right. The literature that you do minimally invasive for this kind of large hematoma herniation is just evolving. So for that group, really just the normal usual open craniotomy, take out a clot. That's really the level of evidence that is not even in stitch, right? The stitch itself is also equipoise. Yeah, I'm not going to confuse you. I'm saying if it's dangerous, unilateral pupil dilation, fairly large clot, you want to save the patient's life, operate with the traditional approach. Okay, the literature for minimally invasive for that group of patient is only starting to emerge, and you definitely shouldn't say that if patient is herniating, you bring the patient in and pop in and BrainPath. Please don't do that. Not at this moment. All right, the literature is only coming. So then you will be that group of patient which is a moderate size clot, let's say 30 to 40 cm, and the patient is fairly well. You have documented that actually over the 8 hours is very stable, but it's a fairly sizable clot. That's when we start to consider the clot evacuation through this minimally invasive. At least that's from what I do. Thanks.
And another question is, how about the thrombolytic agent in your country? Because in our country, we do not have 1 milligram RTBA available.
Similarly, that's the reason why we did not adopt the MISTI trial. BI Boehringer Ingram only gave us the 25 mg, which is meant for RTPA of the usual stroke. So the 1 milligram is too expensive to open the whole valve, and that's we don't use. So I don't use MISTI technique. This is just the literature of it because of the cost of the RTPA. So what do we do? For example, our IVH, actually we use urokinase, which is very much cheaper, and it seems to work as well. So I don't have that 1 milligram RTPA, really from the cost point of view.
Yeah. And the last question for your presentation is, how do you think about the MIPS approach? That's mean you can also use thrombolytic hematoma evacuation, also use tubular approach, but in the basal ganglia hematoma, according to the DTI MRI imaging, we can assess the patient preoperatively, mostly show that the pyramidal tract almost destroyed. So how about your opinion about the useful for the patient rather than the transient mini or open approach?
Yeah, which is why when I showed that slide itself, you need to be aware of when the vendor tells you these are all the beautiful approaches, the MySpace, minimally traumatic, look at the tracks, look at where the tracks are going and all that. So that's the latest concept, and you need to know your tractography in order to target that. And therefore what they're saying is that it is not the most direct track itself. You have to look at what are the functional tracks itself. If you ask me, I think that's something plus minus. I'm not sure whether it's additional, but well, that's what it is in the literature. So if you go and attend all the courses about the latest paravascular approach and all that, just take it with huge consideration, politely.
But are you routinely operating on large basal ganglia hematomas?
If there's only sizable effect itself, and if I have to choose between craniotomy and vessel minimalism, then we will use the brain path.
So, but you are actually operating.
Yes.
I mean, at the moment, we're in the evacuate trial, but we're still, as a routine, not operating on basal ganglia hematomas. Probably got time for one more question. This guy's full of questions. All right, you've got one more.
Thank you. Actually, I have more questions, but because the time has limited, so I will ask you 2 questions. It's about the technique when we do the direct bypass SDA-M4. So about I see Dr. Lawton perform the continue running suture, but you and mostly with the new surgeon to Moya surgical technique, that's your simple interrupt suture. Yes, how about your opinion for new member like me to enhancing the timing of surgery?
Yes. So the classic discussion about the continuous suturing versus the interrupted. Number one is the speed, because if you're doing continuous, it's much faster. So supposedly it decreases the ischemic time. If you speak to the Japanese people, then they will say that the idea of the continuous suturing may be more constricting, whereas if you're doing the interrupted, you may be able to allow for future expansion. And so that's the only training. I don't think there's a real, it depends on who your boss is and who trained you. But I personally do interrupted, as I showed you, because I feel that the management of the loop needs a little bit of a skill in order for you to be able to do that. That's just my personal preference.
There's fairly good evidence that a continuous suture in any situation has increased ischemia, tissue ischemia, unless done very well, because it's often too tight. Cardiac surgeons, same. Yeah. They do continuous. Yeah. All right. Have some afternoon tea. We'll see you back for the last session. Almost there.